Thanks very much, Ian. Can everyone hear me okay? Good. So, oops. There we go. I'm going to be speaking today about managing advanced frailty, people with, end-stage dementia, and what can we do for them to improve their quality of life. So the learning objectives, and I'll just backtrack. This started as a presentation for the hospice course. How many people have done the hospice course? It's a fantastic course. You may have heard me do this presentation. And they asked me a couple of years ago to talk about palliation for Alzheimer's disease and dementia. And that's how this came together. So the objectives for the talk are going to be able to recognize the burden of dementia, both at a population level and at an individual level, to recognize the natural history of advanced dementia, and to recognize how important it is to know that you're getting close to the end, because a lot of people don't see it coming. And identify, at the end of it, you should be able to identify 3 predictors of mortality. The third thing is to talk about how we can sort of approach care planning in a practical way and identify 5 domains of goals of care for people. So goals of care is the buzzword now, in geriatrics and care of the elderly and chronically disabled people. So we'll try and make it more practical and structured. The other is to recognize the impact of polypharmacy and quality of life and frailty. So a lot of the drugs that are really great for example, preventing congestive heart failure may significantly impair people's quality of life. Or a statin drug may make people live a little bit longer, but they may end up with chronic pain from muscle, unrecognized muscle pain. The other part will be to be able to reconcile medication use with goals of care, and finally to recognize some causes of agitation and dementia that may not be sort of on the top of your radar. So the format's going to be fairly practical, 3 case presentations, and I'll say that all of these, I'm an experiential person, and all of the cases I'm presenting to you are my patients. Have been my patients with very subtle modifications for presentation purposes. And we'll also do a brief review of any kind of evidence that we could bring into play to help us understand these problems. So I have no conflicts of interest. I was involved in clinical trials for dementia, but it was 20 years ago. I don't do speaking for drug companies. And the only thing I could say maybe is that I have 1 copy of apolipoprotein E4. How many people have done 23andMe? Raise your hands. Don't. Okay. So this is a very personal topic. So we'll start with the burden of dementia. So we know that dementia increases with age, that by the age of about 70, 14% of people, the population in Western countries, will have dementia. And if you live to be 85 or older, probably 1 in 3 people has dementia. And by dementia, I mean people who have cognitive impairment that affects their daily function. That's sort of the broad term for dementia that I'm using. And I read an interesting statistic that there's 1 case of dementia diagnosed every 68 seconds in the U.S. It's amazing. And if we don't find a way to slow down the progression of this disease or to treat it, there's going to be a tsunami, and we're starting to experience it now. The economic burden of dementia is enormous. They estimate that there were $33 billion spent in 2015. This was from the Alzheimer's Society of Canada. This was in Canada. And that includes both the direct medical costs and the indirect costs, which far outstrip the direct medical costs. So that's all of the lost work for caregivers who have to look after their parents and look after their loved ones. In terms of survival from diagnosis, the average is about 4 to 8 years, from the time someone walks through the threshold where, they got lost when they were driving, they screwed up their, balancing their checkbook, they clinically had dementia. Now, we know that dementia probably starts, and certainly Alzheimer's disease, probably decades before. That's what we're learning now, before the actual clinical, presentation of it. But once people are diagnosed with dementia, the average life expectancy is about 8 years for people. And some people you'll see will live up to 20 years from the time of diagnosis. And we know the other part, the important part, is that 40% of that time is spent in a stage of moderate and severe dementia. This is where people are really impaired. And that 3/4 of people who end up being diagnosed with dementia will end up in a nursing home. So there's a significant effect on people. How many people have ever seen a patient or client that's voluntarily said, oh, I want to go to a nursing home? I've been doing geriatrics for 25 years, and I've never, ever seen anyone who said, oh, that's great. I'm going to be going to the lodge. The other thing to consider about dementia is not only survival, but quality of life, and there's a significant deterioration of people's quality of life. And it's a major cause of suffering for people at all stages. So we think earlier on, think about the anxiety people have when they're recognized, they're losing their memory, they're not as sharp, they don't recognize people anymore when they run into them, at the shopping mall. And it causes great anxiety. And as they move through the dementia, there are other things that happen to them that are going to affect their quality of life as well. And very occasionally, paradoxically, you see, Dad was a real son of a bee, all his life, and suddenly he gets dementia, and he's a pussycat, So once in a while, you'll see the opposite happen, where people really can just, relax and be themselves. The other thing to think about dementia is that this is a social disease. This is not just something that infects individuals, but it affects everyone around them and everyone who's looking after them, and is a major cause of caregiver burden. And we know that, I don't know what the percentage is, but I would say probably 20 to 30% of caregivers, intimate caregivers for people with dementia, will suffer clinical depression themselves. And this is not a disease that goes away quickly. This is a long-term problem. And the other thing we know about caregiver burden, that even after someone goes into residential care, it's not over. Because you see those same family members are coming in every day and worrying and concerned about the quality of care. So we're going to jump into a case. And this gentleman was an 87-year-old widower who was living in a nursing home for 3 years. He's a retired engineer from Scotland and had a very supportive, loving family. And to the point where they paid for a private caregiver, to come 6 hours per day into this facility. And this was one of the best facilities in town, because they wanted to make sure he was not left alone and there was someone there stimulating him. And he had severe vascular dementia. And if we think about assessing dementia, I really like the ABC approach. A being what's the impact on ADL, B, behavior, C, cognition. So if we break it up that way and look at the ADL, he also had Parkinsonism besides his vascular dementia, and he was in a wheelchair all the time. He was completely dependent in his personal care, his basic ADL. He needed to be needed assistance with feeding, so he couldn't feed himself anymore. And he needed his pills crushed in a blenderized diet because of dysphagia, chronic problems with swallowing, and he was incontinent of urine. In terms of the behaviors, he had agitation, paranoia, and sundowning, which were very well controlled with low-dose risperidone. So this fellow had Parkinsonism, which was probably vascular in his case, and a tiny dose of risperidone, I think was 0.125, or even less than that, was enough to calm him down and give him some comfort without exacerbating his extrapyramidal problems. In terms of cognition, he still had his language. There were only very mild deficits. He had significant subcortical changes and cognitive slowing. So, you would ask him a question and he would answer 3 minutes later. You'd already moved on to a different topic. And then he'd give you the answer to the question. He recognized his family most of the time. He had problems with names, and he was disoriented. He thought his dead wife was still alive. He'd always be asking about his dead wife. In the past year, he'd had 3 episodes of aspiration pneumonia, and his other medical history was unremarkable, and he was on thyroxine, pantoprazole, vitamin B12, a small dose of aspirin, and the risperidone. So this is a very typical scenario for, I know, all the nurses here, that, over the weekend, things went south. And there was a call from the nurse to the on-call physician saying that he's coughing, he's wheezing, he's moaning at times. He's much weaker. He's like a kitten now, crumpled up in his wheelchair, and he's more confused. He's not eating. He's got problems swallowing his pills. His oxygen saturation was 90%. His temperature was 37.7, so he had a low-grade fever, and his blood pressure was low, 108/56. And he had crackles in his right lower lobe, bilateral rhonchi. And the question to the doctor is, should we send him to emerge? Okay. What would you do? What would you do in this situation? How many people have encountered this? Show of hands. Okay. Should we send him to emergency? Anyone have any thoughts about that? A lot of heads going like this. And do you remember this fellow's having trouble swallowing? So if you're going to treat him with an oral antibiotic, it would be challenging to do that. So I just want to lay this scenario. That's part of what the nurse said to the doctor, right? So I'm going to back up a little bit now and share a little bit of evidence. This is one study that really, really changed my practice. And changed my practice, enlightened me, gave me some fantastic tools, and I want to share that with you. And this is called the Cascade Study. It was published in the New England Journal of Medicine in 2009. And what they wanted to do is study the clinical course of advanced dementia. Whoops. Technical help, I will need it.
Keep talking.
So I'll sort of tell you a little bit about the study while Ian's getting this ready. I guess I won't. Sorry, that apolipoprotein E4 is kicking in. There we go.
I don't know what that screen is. Can you switch it over here?
So this, the Cascade Study, we know that as the mortality is rates from leading causes of death are dropping, like cardiovascular disease, stroke, cancer. Death from dementia is increasing. We know that, so what they did is they assembled a cohort and followed these people with advanced dementia for 18 months by assessing them every 3 months. And they enrolled 323 people with advanced dementia who had healthcare proxies. So they had to have a family member or someone who was intimately involved into the study. And the average age of people in the study were 85. Their cognitive performance scale in the MDS, which is done in the nursing homes to the bane of all nursing home assessors, was 5 to 6, which is equivalent to an MMSE of 5. So these people had quite profound dementia. Their GDS, or Global Deterioration Scale, was 7, which meant that these people were, at the bottom. They didn't recognize their family. They had minimal verbal communication. They were mostly non-ambulatory, incontinent, and 100% dependent in their basic activities of daily living. And you can envisage these people in wheelchairs and, sitting in hallways in nursing homes. And on the average, they had been in the nursing home for about 3 years. And they recruited people from 22 nursing homes in the greater Boston area. So what they found was that, at the end of the 18 months, 55% of the people had died. And the median survival was about 16 months. But they noted also that about a quarter of the people died within 6 months. And they found that there were really 3 predictors of 6-month mortality. One was if people had a history of pneumonia, which were 47% of the people. The other is if people had any febrile illness, so any kind of febrile. It didn't have to be pneumonia. It could be the flu. It could be a UTI. And the third thing was that people who have eating problems. And we know that when people have eating problems and need to be fed, they're much higher risk of aspiration and all the complications that go with that. And that these people had substantially higher mortality than the rest of the cohort that was being observed. Now, the other interesting thing about this is they found that other sentinel events did not predict death. So an MI, a seizure, a stroke, a hip fracture were very poor predictors. But if you had a swallowing, an eating problem, if you needed to be fed, if you had pneumonia, if you had fever, it was a very strong predictor of death. And this is a graph just see here. Does this work? Whoops. So this is a graph. If you look at the purple line in the middle, that's the probability of someone dying over that 500, 600 days. And you can see that roughly 55% of people, there it is, that one right there, would died during the study. And that if over the study period, 85% of people would develop a problem with eating. So these are people at the beginning of the study, had no problems with their feeding or eating, and by the end of the study, they had trouble eating. We knew that the incidence of a febrile illness was 53%, and pneumonia was about 40%. Now, this is the interesting graph, and if you look at these, is that working? If you look at these slides, that if someone, the top line on each one is people who did not have an event. So if someone did not have pneumonia during the period, and then they survived to about 80% of people were still alive at the 18 months. If you develop pneumonia, your survival dropped right down to about 40%. Can people appreciate that? And the same thing for febrile illness. The people who had good immune systems, those people were still alive at the end of the study compared to people with a febrile illness. Suddenly their survival, went right down. And the most stunning, biggest curve here was the one about eating problems. You can see if you had no trouble, if you could feed yourself, you had no trouble chewing, you didn't eat a blenderized diet, the vast majority of those people were still chugging along at 18 months. But once you developed that problem, you could see that the curve just dropped right down, and these are the people who are dying. Now, the other thing that was quite interesting about this study is they also looked at quality of life, not just survival, because that's probably the most important thing in frailty. And they found that the majority of people, probably 40 to 50% of people had distressing symptoms more than 5 days a month in this population. The most common ones were shortness of breath, pain, agitation, choking. So aspiration isn't just a matter of silent aspiration, but you'll see a lot of these people, they're coughing and choking as well at mealtime. And about 40% of people had decubitus ulcers. And I think most people would agree those are symptoms that can negatively affect people's quality of life. The other thing they looked at was burdensome interventions. And they found that in the last 3 months of life. And they found that 40% of people who were dying in the last 3 months of their lives were sent to hospital. They went to acute care, to emergency rooms, they were admitted, they had IVs put in, and even 7% of people had feeding tubes put in. Now, they took it one step further and they interviewed the caregivers, and they asked caregivers what they thought was the primary goal of care. And the vast majority, 96%, said comfort. We want our loved one to be comfortable. And that, but only 20% believed that their family member was palliative. Most of them thought they're just going to keep going the way they're going. And only 18% reported that they got any counseling at all about prognosis from a doctor. So the vast majority of people thought they're just going to 80% or they're just going to keep going. And the interesting part was the people who got the counseling, they understood what was going on and it changed what their decision making. And those people had much fewer burdensome interventions, much fewer transfers to emergency, much fewer IVs, etc. And in fact, the odds ratio of having a burdensome intervention was 90% lower, 88% lower, if you spent a little time counseling these people. So any questions about the study before I talk about our case? So we're going to come back to reality. So it turns out this fellow was sent to emergency, and he was delirious. He pulled his IV out. So the benefit of sending someone with, dementia and delirium for an IV treatment didn't pan out for this fellow. And he was discharged back to the to the facility on moxifloxacin, and he was a little bit better. 5 days later, he relapsed again. He was increasing distress. He had persistent crackles in his lung, low-grade fever. His oxygen saturations were dropping now. 88%. He had difficulty swallowing his pills. He was coughing even with his puree. He was like a kitten. He was just very, very weak. And we spoke with the family, and really the goals of care were comfort and alleviating suffering. And this is a family that adored this man, and it was very hard for them, the idea of letting go, that this man was dying, but they understood it. And we stopped the oral medications with him, put him on subcutaneous hydromorphone and some lorazepam and a little bit of atropine, and he died peacefully in his room where he'd lived for a couple of years, 3 days later. Any questions about that case? Okay, or comments? Does that sort of resonate with your experiences? Yeah. Now, the second case I'm going to talk to you about is someone without significant dementia, but with quite advanced frailty. And how do we sort of try and establish goals of care and manage polypharmacy? So this gentleman was an 83-year-old retired commercial pilot from Vancouver who was married and had a devoted, loving wife and a supportive daughter in Victoria and a son in Vancouver. And he was transferred to residential care after very prolonged hospitalization. He basically came to visit his daughter. He walked through, into, off the airplane and came in. He had a little bit of a gait disorder. I'll talk about that in a minute. And ended up ending up in the hospital and spent like 7 months in the hospital and was transferred to a nursing home. So this fellow was completely independent, hiking the grouse grind until 2 years prior to this event. He had been diagnosed with prostate cancer with pelvic metastases and was treated with chemotherapy, radiation, and Zoladex. And the year prior to admission, he developed this really probably a paraneoplastic syndrome with a progressive gait disorder, balance problems, significant tremor. His whole body was shaking. And that's when he had this fall, which changed his life. His other past medical history was unremarkable. He had hypertension, he had high cholesterol, and he was a non-drinker and a non-smoker. This guy was a real going concern until he got sick. And the initial assessment with him, his MMSE was 20 out of 30. He had some very mild, sort of on the edge of dementia, mild dementia. He scored 0 to 5 on the short geriatric depression scale. He did not have any depressive symptoms. He complained of pain in his back and his legs. And there were no really significant findings except he had severe muscle wasting in this sarcopenic picture, very low muscle mass. He had this neurodegenerative diagnosis with ataxia, he had significant ataxia, trouble with his, trunk stability, tremor, rigidity. And he was very frail. This guy needed a mechanical lift, total care for his basic ADL. He had trouble sitting up without being supported. He had very poor stamina and the severe fatigue and weakness. He also complained of dizziness whenever he stood up or went from a lying to a sitting. He felt really dizzy and felt horrible, like this coat hanger headache that Alex talked about. He had severe dysphagia and dysarthria, but he refused pureed foods. And I'm not eating baby food. That's one of my last things I enjoy in life, and I'm going to eat what I want to eat. With it, he coughed and choked and sputtered, but that was his choice. He had this severe tremor, which affected his ability to feed himself because he was shaking so badly, or wipe himself, or do things. And he also had problems with diplopia, double vision, so he couldn't read properly. And he was a big reader, and even watching TV was challenging for him. And he was incontinent in pads and had severe constipation. The only other physical findings with him was his blood pressure was low, 104/50, and he dropped down to 94 when he sat up. That's going from a lying to a sitting. And he had severe edema. His legs were just weeping. They were huge and weeping and springing leaks, all over his, below his knee. And the final thing was that you could see his wife was very, very burdened. She wasn't sleeping. She was waking up with him multiple times a night to help him with the toileting. And she was just exhausted. This garbage pail was his medications, okay? He was on 17 drugs, okay? And I'm not joking, this is an actual case. So, and the first challenge I get when I get this sort of big list of drugs is try to match up what could the drug possibly be for, right? because maybe there's a good reason for it, right? So I looked through the hospital chart because, I thought for sure this guy must have congestive heart failure because he's on beta blocker, ACE inhibitor, diuretics. But there was nothing to ever suggest he had CHF. So he was on atorvastatin, and it was for primary prevention. He had a high cholesterol, but he never had vascular disease before. He was on amlodipine for his blood pressure at full dose. He was on ramipril 5 BID for blood pressure, metoprolol, furosemide for his edema and his blood pressure. He was put on a nitro patch. He never had angina, but he had severe hypertensive crisis. And the reason for the hypertensive crisis in the hospital, because he was so angry about being in the hospital, he had a fight with his wife. He said, if you don't get me out of here, I'm going to kill myself. Right? And he was like beet red. And then they, his blood pressure went to 220 systolic, and they slapped a nitro patch on, and it never left his body. He was on aspirin, again, for primary prevention, if we go back to it. And we know there have been studies published recently that there's no evidence that aspirin is useful for primary prevention in older people. And it just increases the risk of bleeding complications, including intracerebral hemorrhages. He was on alendronate, 70 milligrams per week. He had someone had thought he had osteoporosis with his sarcopenia, but he never had a fracture. Okay, he was on calcium, vitamin D for the osteoporosis. He was on the Zoladex for prostate cancer, bicalutamide for prostate cancer, sertraline for depression and anxiety, when in fact the depression and anxiety were really anger and frustration at being locked up in a hospital and not being able to do the things he wanted to do. He was on Dilantin, 300 milligrams, and for seizures on this discharge summary. And what was the seizures? He had a faint followed by, a couple of seconds of shaking. He had a vasovagal spell. And he'd had a couple of these, so he got put on Dilantin, okay? And he was on Zopiclone 7.5 to help him sleep. And he was on potassium because of the Lasix and B12 1,000 and ferrous fumarate and on and on and on, right? So people got a feeling. How many people have seen this? Lots of people, right? And the challenge becomes for us is what can we do about this situation? Now, the other thing I like to do is lab tests on people. I want to get a better sense of what's going on with people. So we checked his hemoglobin, it was 102. He was anemic. His lymphocyte count was low, which again shows that he's at risk of infection. It's a good marker of frailty in the immune system. His B12 was off the map, and this guy was on 1,000 micrograms of B12, right? He's on iron, and he's has severe constipation and nausea, and his ferritin was 190. Okay, his TSH was non-detectable, and his T4 and T3 were both up. This fellow was thyrotoxic. That was part of the reason he was shaking like a leaf. His albumin was low. He was malnourished. His urea was a little bit up from dehydration, and his GFR was a bit low. His lights were normal. His PSA was 16. And I want to ask people, at what PSA level does prostate cancer usually metastasize to bone? Do people know? Usually it's over 20, okay? Usually, certainly over 15 and, closer to 20. So if you have a lot of people, who are older and they've got prostate cancer and their PSA is 10, leave them alone. They don't need, anti-androgen therapy and things like that, because it's when they start creeping up into the high teens. Now, this fellow's a little bit different because he had pelvic metastases, and that's why he was being treated. And his liver function was normal. So what would you do for him? This is where we get a little audience participation. And he just scream it out without too much rage. Anyone? Sorry? David?
Stop everything.
Okay. So one thing is stop the whole pile.
Stop the whole pile,
right?
Start again.
Keep it in that garbage pail. Okay. So how do we do this systematically? This is the challenge, right? So one thing is to back up and say, what are the goals of care? And this is something I found useful when I'm talking with people, is to divide it up into what are the symptoms that are disturbing, or that affect their quality of life? What are the functional parts that are important to them? So some people don't care if they're not walking. They're quite happy to be in a wheelchair, electric wheelchair. So why do they want rehab or something that's going to make them walk? They don't really want it anyways. So what are their functional goals? What medical interventions do they want, right? How important is survival to them? For some people, I've got 99-year-olds who said, I want CPR, right? They're still, got living every single breath of their life. So you have to individualize that. And then the other part would be the caregiver burden. So if we talked about this fellow, when we asked him what were the things that were driving him crazy and making his life miserable, he said, I hate being so dopey. I can't stand it. I can hardly stay awake. I can't stand the fatigue. I can't even talk to my daughter when she comes to visit because I've got to lie down. I hate the dizziness. Every time I sit up, my head is just spinning. It just feels like a load of rocks inside my head. He found that the pain in his back and legs was very disturbing. He said he wished he could enjoy his food again. He had no appetite whatsoever, and he was like a foodie. He wanted some relief. He had painful constipation. Every time he had a bowel movement, it hurt him. And he also wanted some relief. He was waking up every hour with nocturia and some relief from the uncomfortable edema. His legs probably had about 20 pounds of water, in his legs. Functionally, he said, if I could, get rid of this tremor, I could, that would really make my life better because then I could feed myself. I hate being fed, people trying to feed me. It makes me feel like an infant, and, I can't stand the thought of it. This guy was really with it, and also be able to, handle his morning care. He also would like to get out of diapers. In terms of his social function, he said, I wish I could stay up longer. I already mentioned this with his daughter without tuckering out. In terms of medical interventions, he was crystal clear, absolutely no CPR. Even if CPR worked 80%, even though we know it works, what's the survival rate for CPR in the community for somebody who's over the age of 65? Anyone want to take a guess? It's 3% in good randomized trial, good clinical studies under best circumstances between 3 and 7%. And in a hospital setting, it's not that much better. It's probably about 15% to 20% best case scenario. That's 1 month survival, okay? So this guy said, told me, no way, I don't want CPR. I'm not going back to hospital. No tubes, no injections. I'm done with the Zoladex. I'm tired. I don't want to go to medical appointments. This is a big problem with older people, is that, going from one specialist to the next. And he said, He said he was okay having blood tests as long as they were done at home. And he said antibiotics are okay as long as they'll make me feel better. So if I feel sick and not unwell now, I'm okay taking an antibiotic. In terms of survival, he said, I'm ready to go. And he didn't want anything to prolong his life. And he said he wished there was something he could do to alleviate his wife's, caregiver strain. Now, when I spoke to his wife, it's a different picture, right? What are your goals? Delay his death as long as possible, including CPR. She loved this man. She adored him and did not want to let go and was not ready to let go. She said hospital for any illness. As soon as he's got a fever, send him. This was where she was at. And also, of course, improve his comfort. So the challenge we have now is how do we sort of braid these two divergent goals of care and try to bring these together into one pathway, not including also the, if you add in the other layer in a facility where you've got to bring the team involved, and what do they see as the goals of care. So I like to set up put these goals into a grid and say, what are the factors that are contributing to these problems? What actions are we going to take? And then say, is there something we can objectively evaluate to see we're getting where we want to go? So if we look at the fatigue, dopiness, weakness, this guy was hypotensive. He was oversedated, he was thyrotoxic, and he had some renal failure. So we tapered him off Sopiclone. We tapered him the dose of Dilantin, and I think last time Alex said you can just stop Dilantin because it's got a very long half-life. We tapered him off all of his blood pressure pills and the Nitrodur. We stopped it all. And we stopped the Zoladex and the biclutamide, and we treated his thyrotoxicosis. We put him on Tapazole, methimazole for the thyrotoxicosis. And, by golly, he was sleeping better. A month later or 6 weeks later, he could stay up for 3 hours at a time without saying, I need to go lie down again, sitting up. And we had to put him back on Ramipril because his blood pressure went up to 180, 190, and he wasn't feeling good. So we put him on a low dose of Ramipril. Follow-up blood pressure was 142, and there were no seizures off Dilantin. That was a year, until his death. He never had one of those so-called seizures, which was probably hypotension, orthostatic hypotension. His dizziness similarly improved. His back and leg pain were caused by torvastatin. With statin-induced, we see this over and over again. People who are older and, they say, oh, my back hurts. I've got arthritis in my knees, but it's actually their thighs that are hurting. And they've got the statin myopathy, which isn't picked up on, with people. So we took them off the statin. We took them off sertraline, and it's important to recognize that SSRIs can cause extrapyramidal side effects with people. They can cause restless leg syndrome. They can cause REM sleep disorder. And this fellow wasn't depressed. In fact, I saw him a number of times, and I'm always, leave, antidepressants for the very last thing I'm going to taper with most people unless their blood pressure is really low or there's something urgent. But we managed to get him completely off, and I can tell you he did not relapse. And we also added in a regular dose of acetaminophen, and we had our physio see him, and he got a Rojo cushion for him and put him, gave him some penitent cream, to toughen up his skin on his coccyx. And at the end of that, his leg pain was gone, his back pain was manageable, there was no depression, and he was sleeping well. And similarly, you can go down the list. His anorexia and constipation got much better with stopping the calcium and the iron, and the aspirin and the alendronate. Alendronate's a very acidic drug. I would never give alendronate to somebody who is bedbound, because they've got to be upright, and that drug has to go right into the stomach or it's going to burn the esophagus. So for those kind of people, if they really need treatment for osteoporosis, we often will go to an injectable rather than an oral bisphosphonate. In terms of the edema and nocturia, the cause of his edema was the amlodipine. He had massive edema and leakage because of the amlodipine. And another common drug so all the calcium channel blockers can cause severe edema. All the gabapentin, some of the anticonvulsants can cause severe edema by blocking calcium channels. And the other one to think about for edema, really bad edema, is NSAIDs, which we don't use very much anyways anymore. And, at the end of it, and the thing to recognize is the edema often ties into the nocturia, because when you lie down flat, all that fluid in the legs is mobilized into the circulation, and people are up all night peeing. So if you can sometimes the better way to treat nocturia is to give them a little diuretic in the afternoon to get rid of that excess edema. Socially, in terms of his social and functional status, he was much better, with all these changes. And he could eat with his left hand, he could brush his teeth again, he could visit with his family. And in terms of the healthcare burden and caregiver burden, we'd cut out the multiple specialists. We canceled all of his appointments, with neurologists and cancer specialists, etc. He was established at a most 2 level, for his care, his advanced care plan. And I spent a lot of time talking to his wife. And it takes time, to do this. But I can tell you it's time worth, spending with people, just like in the Cascade study. That if you take that time and talk to people and explain to the prognosis and grieve with them, because they're grieving as it's happening, then people will buy in, and then you don't get these burdensome interventions. So after the call with this fellow, he was on acetaminophen 500 TID. He was on methimazole 10 milligrams once a day for his thyrotoxicosis, and he was on 2.5 of Ramipril. 9 months later, he had progressive dysphagia because of his neurodegenerative disease, and he was getting recurrent aspiration pneumonia. And I had multiple meetings with his wife, and from his perspective, he said, "I'm done with the antibiotics." We got to that stage where he said, "I don't want any more antibiotics," and he refused transfer to hospital, even though his wife was still kind of hoping. And he reached that point, and we went to end-of-life medications, and he died very, very peacefully with his wife and daughter there. So the last case I'm going to talk about, Ian, how much time do I have left?
About 5 minutes.
Oh, great. Any questions about this gentleman? Anything at all, or, okay? Sure.
I just wondered about his double vision.
Is diplopia. So it didn't correct itself. With all the changes, the best treatment for diplopia is prisms. Okay, and it was a challenge to get an optometrist to come into the facility. I think Brian Friedman will go into facilities. But it's certainly worth doing is getting prisms, and that will 90% of the time will correct the diplopia for people.
Thank you.
Okay, and a lot of times it's imbalance in the muscles. I don't know, Alex, if you wanted to add anything about that. So, any other questions about this gentleman or comments? Okay.
And I think regardless of whether that request is made, you really illustrated a very good palliative functional outline.
Okay, that's a great topic of discussion, and I'm going to park the maid and come back to it at the end if we have some time, because I think it's important to put that on the table too for the cognitively intact people, because we know that if you have dementia, unfortunately or fortunately, whatever, at this stage in legislation, you cannot have MAID. If people have mild dementia and they're still capable in their decision making, they can elect to have, the medical assistance in dying. So we'll come back to that at the end and, talk about it, in the room. The last case I want to share with you is is a case of agitation with advanced dementia. And this was an 85-year-old widow who was living with her supportive daughter and son-in-law in a downstairs suite in their home in Victoria. And she was quite a remarkable lady. She was originally from East Africa, and people may remember, some of the older people in the audience, when Idi Amin threw everyone who was of Indian extraction out of Uganda with no notice. They just pack your bag, one bag, and get out of the country. These were a wealthy family who'd been in a number of generations in Uganda, and they lost everything, moved to Canada, started with nothing, and basically just flourished when they came here, and and made people their community a better community. They're not their community, their East Indian community, but the greater Victoria community. And if I say I can't say the name of this family, but I'm sure some of you know them. But they're just outstanding people in the community. And she was high school educated. She worked in her family business. She had advanced Alzheimer's disease with a small component of vascular dementia. Her MMSE was 0. She was completely dependent in her care and needed a mechanical lift and needed to be fed. And her family were committed to caring for her at home till the very end. There was no way she was going to go into a care home, and there was no way she was going to go to a hospital. And they had 2 live-in 24-hour caregivers. Unfortunately, these people had enough money that they could afford that kind of care. So her past history, besides the Alzheimer's disease, she had lacunar infarct, she was diabetic, a vasculopath, hypertension, MI, she'd had a history of depression, she had reflux, and she had osteoarthritis. And these were her medications that she was on. She was on Zopiclone 7.5 milligrams at bedtime. She was on venlafaxine, 75 milligrams. She was on Risperdal, 0.25 milligram BID. And if she didn't take the Risperdal, like we know that there's always this thing about antipsychotic drugs, like the sword hanging over our heads, never prescribe them. But if you took this lady off the Risperdal or lowered the dose, she cried all day and all night, and she was hallucinating, and all she did was she was looking for her mother. And when she went back on the Risperdal, all of that paranoia and the hallucinations and the angst and the anguish went away, right? She was also on memantine 10 milligrams BID, and if she was taken off the memantine, which is Therapeutics Initiatives tells us it's a useless drug, she could not follow any instructions whatsoever. Put your arm in the right sleeve. Didn't happen. She couldn't do anything. She just cognitively froze. and it also helped her with her sundowning. Cholinesterase inhibitors did not help this lady. She was on amlodipine 10 milligrams, and you wonder why would you treat someone with advanced end-stage dementia with blood pressure pill? But if she was off it, her blood pressure went to 190, and she became moribund, and she got more confused, and she slept, and they wanted her more with it. And finally, she was on Lantus insulin 5 units, and if she didn't have that 5 units of Lantus, her blood sugars went up to 28. So she was had become a type 1 diabetic. And if you follow these type 2 diabetics over time, eventually their pancreases completely go and they end up with a type 1 picture. So the problem with her was that she had a relapse of her agitation, her so-called BPSD, behavioral and psychiatric symptoms of dementia. And she was calling out, and her caregivers, she was calling out all night long, and her caregivers were absolutely exhausted. She was anxious when she was left alone. She was, sobbing again, looking for her mother, and she was screaming with care. And the caregiver said, I think it's her knee, because whenever we put her in the sling, she yelps, and she, yells a little bit. And they thought maybe it was the osteoarthritis in her knees. She always was peaceful when her daughter was around, and you can imagine this lady, she had her plush doll tucked underneath her armpit, and that gave her comfort. Examining her for the agitation, really there was nothing. She had earwax and she had some dental problems. You could see there was some infection in her mouth, and her labs were unremarkable. And the problem was that the situation was not sustainable now. So the caregivers were going to quit. And if the caregivers quit, the live-in caregivers, it was a house of cards. It was going to collapse. And the daughter was in tears saying, what am I going to do? What am I going to do to keep mom at home until she dies? So the goals of care were really to reduce this lady's distress. Survival wasn't a big issue. They were happy she was alive. But they did say that they didn't want anything that would hasten her death. They were religious people, and they felt, I don't want you to do anything that may make her not live as long as she possibly could. So I'll back up and say survival was an issue. They wanted her to die at home. But they needed to be able to do her care, and they needed the live-in caregivers to be able to sleep at night. And they didn't want transfer to hospital. So what would you do for this lady? Anyone have any ideas? Because we've got a crisis, right? This is a crisis. Anyone have? Pain meds. Okay. Okay, what would you do, Ian, for pain? Any ideas? I don't remember. I don't think so. Okay, so she's not on Tylenol. Tylenol's a good start. Okay, anyone else have any ideas? Okay, so I want to back up, and pain that's a great lead in, Ian. And I want to share with you another study, which again I thought was a really good study of analgesia for people with behavioral problems related to dementia. And this was done in Norway, and it was a clustered randomized trial where they were randomizing not individuals, but they were randomizing nursing homes, facilities to analgesia, stepped analgesia care, or usual care. Do what you normally do for people with agitation, behavior problems. And in these facilities, the average MMSE was 8, and the randomization was basically stepped analgesia, where it was started with acetaminophen, went to morphine, went to buprenorphine patch, and then also pregabalin. People had the discretion to add in pregabalin if they thought there was a neuropathic component. And you can see at the end of the trial, about 70% of people were on acetaminophen, only 2% of people were on morphine. And, you have to ask the question, is morphine a good choice if you're going to use a narcotic in an older age group in a facility? Because, it's got complicated metabolism, and, people have renal failure and problems like that. And about a quarter of the people, a fifth of the people ended up on the buprenorphine patch. And the other group got usual care, which is do what we always do every day in managing people. And if you look at this, I'll just show you one curve from this, is they used what they called a Cohen-Mansfield Agitation Index, which is a gold standard for measuring, agitation in demented people and, who are quite impaired, who aren't verbal. And they found there was a 17% reduction in the CMA-AI compared to the usual care group, which was statistically significant. They also use the NPI, which is another well-validated tool for measuring neuropsychiatric, it's a neuropsychiatric inventory, which is a validated tool for measuring behavior problems with dementia. And they found there was a 9-point change in it, which was significant. And they found that in the intervention group that this reduction in agitation was not at the cost of a chemical straitjacket. It wasn't that you were over-sedating people and they just weren't talking anymore. So there was no change in ADL and there was no change in cognition. Okay? So we're going to come back to Our Lady. So what do we do with her? If people cannot hear and cannot see, they get agitated. So we syringed her ears to make sure that she could hear. We got a dentist. They had a family friend who was a dentist who came to the house and extracted her bad teeth in the home. We tried tapering her off the medications in case they were no longer not only not useful, but maybe causing problems. We know that risperidone can cause, problems with EPS, and people can get restless legs, with it, and that can cause agitation. And, each medication we systematically tried, things got worse. And we added acetaminophen up to 1,000 milligrams 3 times a day, and there was a slight improvement. And we injected her knees with triamcinolone, and it really helped. Just that that injection, steroid injection in her knees, it helped with her transfer and care. That part went away. She wasn't yelping and screaming anymore. The other thing we did is we added in buprenorphine, 5 micrograms. And before using buprenorphine, we started with hydromorphone, and it caused a severe escalation of confusion, 0.5 milligrams, and she was in another world. We gave her Sufenta for incident pain, before the transfers and before the ADL, and she slept for 10 hours, and the daughter was going to kill me. She said, she said, "What did you do to my mom? I'm never going to give that drug to you." And we used a tiny dose, it was like a microscopic dose of Sufenta. And we tried fentanyl at 6 micrograms, but she was too sedated and sleeping most of the time. And then we went to buprenorphine. And why do we wait for buprenorphine at the end? Is because it's not covered by pharmacare. And I think this is an excellent choice of a narcotic in an elderly population, in a frail elderly population. And I do hope that the province will change their mind about covering this drug. The advantages of buprenorphine patch is it's once a week. It's not every 72 hours. It's got a ceiling dose. Once you get to 20, if you give more, it becomes more antagonist and agonist, so it doesn't work as well. So there's not that many for like dumb people like me. It's really easy. It's 5, 10, 15, 20. Stop, for it. And the other thing is it's not excreted through the kidneys, so it doesn't pile up. So if you've got people with chronic kidney disease, it's good. And finally, it's one of the ones that is less likely to be constipating. So it's, useful because the constipation could be worse than the pain for some people. So at the end of the day with this lady, her calling out had stopped. She was sleeping through the night. She was okay with her ADL. We were actually able to taper down the risperidol, to taper right off the risperidol. And we'd reduce the zopiclone to 3.75 milligrams. So it was a win-win-win-win, in the situation. And we'd really dodged a bullet. Well, things don't often stay the same. Good times are great. It's sort of like the Buddhist. We have our cravings. We always want it to be good, but that's not life. So 6 months later, I got a call. Her agitation was escalating. She was calling out and she was crying at night again. And they found that they couldn't even turn her at nighttime because she'd scream every time they turned her. And she screamed at the top of her lungs every time they did care and transferred her. What are we going to do for her now? You guys have to talk a little louder. Sorry, over in the mic. Pardon me? Okay, so what would you do with the pain meds? She was on acetaminophen, 1,000 TID. Do you think going up to 4 times a day is going to make a difference? My experience, not. We were at 5. So she was on a tiny dose, right? So we got room. Good, excellent. Okay, so we could increase her pain meds. So in fact, that's what we did. We got it up to 10 micrograms of buprenorphine. But when we went to 15, she couldn't tolerate it. She was sleeping all the time. And there was only a very slight improvement, very, very slight. And the family felt, it was still a huge problem. They couldn't do her ADL care. So the interesting thing, the penny drop for me, was when I examined her. And I come back, we're doctors and nurses, put your hands on people, right? And when I did her blood pressure, she screamed. She screamed, with the blood pressure. And I've done her blood pressure many times before that. And why did she scream? I noticed as I touched her other arm and she screamed, and I touched her shoulders and she screamed, and I squeezed her thighs and she screamed, and when I touched her knee, she didn't say a word. And this lady had polymyalgia rheumatica, okay? And her, I thought, this could be going on. We did a CRP. It was elevated at 20, which, sometimes it'll only bump up to 8 or 10. And I thought maybe this is PMR. And we were left with a little bit of a conundrum because she was diabetic too. But I put her on, what I do with polymyalgia suspects is I put people on 15 or 20 milligrams of prednisone. I'd often usually go to 20 because some people, 15 isn't quite enough for 1 week. It completely stopped everything. Screaming stopped, ADL was great. She was like a pussycat. She was smiling and babbling and talking, and there were no problems with her transfers. So what we did with her is her blood sugars went up very high with the prednisone, so I could have increased her insulin. But what we do is we'll often change people to injectable Depot-Medrol. And often we'll give 120 milligrams of Depot-Medrol every 3 to 4 weeks. And that's the equivalent of giving someone 5 milligrams of prednisone a day. So you have a much lower steroid exposure. So our nurse came every 3 to 4 weeks and gave her an injection, and that was the end of the problem for her. So any questions about this case before I conclude? And then we can talk about any sort of issues like MAID, or issues like that. Any questions about this particular case, about PMR or pain control with people with dementia? Okay. So in conclusion, advanced dementia is a palliative diagnosis, and it is no different than metastatic breast cancer. In fact, it's worse a prognosis, because now there's often good treatment for metastatic breast cancer or class 4 congestive heart failure. So the 6-month, mortality is, for people with advanced dementia, is 25%. And the other thing is that most of these deaths are predictable, and they're not precipitated by sort of, acute events. That there are three predictors, and if you keep these in your back pocket, it's going to give you great help when you're talking to families. So we know that if people have feeding problems, their brain is not connected to their throat anymore. They're at the end of their life, and they're going to aspirate. They're going to get pneumonia. If they have pneumonia, that's the second sentinel predictor. And any febrile illness, not just pneumonia, but any febrile illness also increases their probability of death. Now, that does not mean that everyone who gets pneumonia is going to die in 6 months, We're talking about averages. And you'll see people that they keep getting recurrent aspiration. They may live 2 or 3 years. But on average, that's where things are heading. The other thing to recognize is that distressing symptoms are very common in this group, and they're often, neglected. And the pattern of distressing symptoms is similar to terminal cancer: pain and nausea and breathlessness and choking and things like that. They're underreported and they're undertreated. The good news story about this is that if you spend time with caregivers and proxies and you establish some goals of care, you can prevent burdensome interventions, you can keep people comfortable, and you can maintain their quality of life till the end of their life. The other conclusion is to think, when you're thinking about goals of care, try to break them up into domains, into something that's manageable. So when I think of quality of life, I'm thinking of symptoms, in my mind, pain, shortness of breath, itching, something like that. Think about function, and again, try to individualize it. Think about what their healthcare goals are, what their caregiver burden is, and what they feel about survival. What do they want? And document that. And then when you look at your medications, try to link those up to the goals of care. Are they fitting the goals of care? So, particularly with people with, advanced dementia, prevention of long-term complications really is not that important. And for a lot of frail elderly people, so giving someone, for example, guidelines tell us if you have protein in your urine with diabetes, you have to go on an ACE inhibitor or an ARB, That's what the guideline tells us. But how long does it take to get kidney failure, on someone with type 2 diabetes? 15 or 20 years. And if someone's in their 80s or 90s, it's very unlikely that'll ever happen, So you can start to ask those questions. The other thing is to think about the medications, or that the adverse effect of the medication may be a lot less tolerable with advanced frailty than they would be with a younger person. And the two drugs I think of most commonly would be metformin and anorexia. You know, I like food, I like eating, and there's not much more you see these people, in a care home can do. And if you give them metformin and it takes away their enjoyment of the food, they don't need to be nauseated or vomiting, but if they stop eating, that's important, right? If that's important to them. Similarly, you think about statins and pain. And the third part of the medications that we didn't really talk about, we talked a little bit about, alluded to, is pill burden. And that's people having to swallow a heap of pills every morning, or multiple times during the day, and especially when they've got swallowing problems. For a lot of people, they just look at it and they feel like gagging. Okay, the other part is to individualize those goals of care, the interventions, but we need to synchronize that. We need to get each other on the same page, and this is the challenge, and this is the fun part. I look at this as the part that's really enjoyable part of medicine, is to sit down with the patients, their families, the healthcare workers, and try to bring people to some kind of consensus. The other thing is to cautiously use palliative medications, even if people don't have cancer, okay? And I think we all, I did this a couple of years ago, but I think the, culture has changed a lot. In the ensuing time, people are familiar with the PATH program, the palliative and therapeutic harmonization, so that, and again, we've talked about this, that people with advanced dementia, most of these people have a lot of other symptoms that need to be treated. So cautiously palliate people as you go. And you have to be a little careful with this frail group because they're more sensitive to side effects. So I see a lot of people in the community say, you've got to palliate this person and put them on morphine. Why aren't they on morphine or hydromorphone or some narcotic? And you give it like this Our Lady, 0.5 milligrams of hydromorphone, and she just didn't wake up, until it wore off. So you have to match it to the individual goal of care. There's not a cookbook approach. The other thing is to always deploy end-of-life backup orders, especially in a facility environment. And how many times I know nurses are just flummoxed and struggle and frustrated that on the weekend something happens to someone and there's nothing in place, right? And they're choking and they're gagging and to get the doctor and call, and who may be reluctant to prescribe a narcotic or to move into end-of-life care, with someone. So always think proactively and say, this person needs to be fed. They've had pneumonia. They've had a febrile illness. They're palliative. Let's put the backup, sign off on all those orders so that the nurses are good to go if there's a problem, after hours. The other thing is to always try to mobilize other resources and supports. And, we're fortunate in facilities. People have, various degrees of physiotherapy and occupational therapy and nutrition, speech-language pathology. In the community, it may be a little bit harder to mobilize some of those resources, but they're there. And also think about geriatric psychiatry, particularly in facilities. I think most of the facilities now have geriatric psychiatrists who can help you deal with some of the behavior issues. And I will stop there. Okay.